Okay, well, thank you, Carolyn and John. What I gathered from what you were, am I on? Okay. What I gathered from what you were saying is so not only don't we have enough capacity in terms of just sheer personnel, but of the personnel that we have, they are undertrained and unprepared. Is that kind of a fair characterization? And I'm just wondering if you sort of comment on just one particular aspect, the sort of provider training and education part. You know, if there were just one or two things that you would say we need to focus on as a particular driver, or you know, possible policy change and or broader cultural change, you know, what would you say that would be? How could we change that calculus?
So I think first and foremost, and being a family physician, I feel like I can say this, is that physicians are not the center of the earth. I think there are a number of health professionals that really can provide care at least as effectively, and in some cases more effectively than providers. So I think we need to broaden the scope of who provides care. I also think that we need to have a more consistent view of obesity as a condition across the entire spectrum, both not only in the health systems, but also across the community. And I think that's one of the pieces of work that we're doing right now, is to really come up with common competencies across health professionals to really make sure that we're all singing on off the same page.
Yeah, I would add to that. I completely agree. But even though the PCP is not really the best equipped to do all of this, and that there are others who are more qualified, exercise physiologists and dietitians and social workers and psychologists, they, you know, we're looking at the PCP still being the sort of gatekeeper for this, and we really think that doctors do need to be trained to know about nutrition and physical activity and preventive care for obesity, and they can then go out there and have practices that are really multidisciplinary, to have dietitians and psychologists and exercise physiologists right there on site. So then the doctor is still making the treatment plan, but he or she has a cadre of interventionists that can help get that going, because the doctor, they can't do it all in their 15 minutes, as you know. So there have been PCORI grants and other grant mechanisms to try and study this to see if it can be done, and they employ DPP-like programs. How can you scale the DPP to be used in a multidisciplinary program, for example? And I think that really is the way that most people are looking at it. And it, you know, we're never going to have enough obesity medicine specialists, certainly in the next 20 years, to even start pushing back on this problem. So we need to develop programs like that.
Mm-hmm. So clearly, you know, the implication of all of this is that we need to expand the team. That's going to be part of the treatment and management of the disease. And Dr. Apovian, I was curious about your reaction to the schematic that both Don and I put up, which is basically saying that, yes, the team itself needs to be expanded, and there needs to be also a much more enhanced patient and even family engagement, you know, in this process. And, you know, in relationship to the programs, we need to find better ways to connect patients to these, you know, sort of more community-based programs where they can access it, you know, on their own. How do you react to that particular model, and how do you think the field would respond to that suggestion?
I think that is a great model. it reminds me of the DPP YMCA program that really, really worked. And then what happened was apparently nobody went to the program. We showed it worked, and it worked for a certain group of patients, and then nobody went. So it means to me that somehow, you're right, we need to connect the doctor's office with the YMCA that has the program, with the rest of the community, so that there is a connectedness, and physicians' practices know where to send their patients, and then it will work. We have whys all over the place. It boggles the mind as to why it doesn't work. And a big healthcare plan decided to take the DPP and try to develop it into a video-based internet program, and that maybe the internet is the way to go to do it remotely, because maybe people just don't want to travel to the YMCA. But then in our underserved areas, we have a disparity there again, because some of my patients don't have access to the internet. So how is that going to work for the people who really need it the most? So there's still challenges.
Yeah, I think there's another tack to take on that as well, and I think accountable care organizations and now accountable health communities actually, one, have the provider groups or the community accountable for the health of their members for basically set fees. And I think what that does is, one, focus on the outcomes, and two, given that you've got a relatively fixed pot of money and fewer rules about who can deliver what, that I think health systems, ACOs, communities can be far more creative on who delivers what services. And maybe it's not the YMCA, maybe it's at your local church or community center. I mean, I think there are a lot of different ways to go at this if we allow the creativity, ask the community, as we heard before, but really understand that what we're focusing on are the health outcomes.
I want to leave some time for any questions from the audience, but if not, I have just a question about, since we've been talking a lot about equity, and both of you sort of mentioned issues around disparities, and I was just wondering, in terms of even sort of access to some of this, what is your sense about access for low-income populations, for let's say treatment issues? You feel it's relatively equitable, or we have issues or challenges on that side too?
It's really bad. So I received a grant a few years ago to focus on our underserved population, and I focused on the underserved minority groups that come to our medical center. And we implemented a diet and exercise program that was delivered postpartum, because we felt that was the best time to react and try to change behavior in women, when it was a time when everything's changing. And it was a great program. Those who stayed loved it, but we had a 50-60% dropout rate because of the barrier that many of these women had even to get to a once-a-week group that they loved, and that they loved. They said they loved learning about diet and exercise, and they loved the types of exercise. We were doing on-site exercise, salsa dancing and all kinds of other things. Yeah. They loved it, but they just couldn't get to us.
Right.
So that's a real problem.
Yeah, I would absolutely agree that access to particularly medical care facilities is an issue. I think it's also an issue that, again, most healthcare professionals aren't really adequately trained to deal with, and really even having the right attitude, understanding that obesity is a condition, it's not lack of will or stamina. And I think the other issue I would point out is that I think some of the most effective ways is when we go to the community, and particularly if the community asks us to come. So in one of the courses I teach, I actually, one of the assignments is for teams of our students to go out to the community and identify a health issue and then to try to help work on it. And we had a tremendous response from African-American barbershops in terms of health education. And really, so again, going out, asking what issues would you like to deal with? And oftentimes we'll see, if you go out and say, would you like to deal with obesity? You don't get that much of a response. If you say, would you like to be healthier or would you like to look better? There's a much better response, and then, okay, what ways can we do it? But it's really engaging the community, seeing what they would like to do. But I don't think we're going to be able to deliver it within the walls of the healthcare system.
Okay. Maybe one, I see Shariki's at the mic, so maybe one question?
Yes, thank you. This is a really interesting discussion. The question is for Carolyn with the findings about the differences in insulin resistance and the difference in weight loss and hemoglobin A1C. So to compare on a group basis doesn't actually tell you if within the group insulin resistance defines those who did better or worse. So I'm wondering if you've done any looking, because there are a lot of other social and behavioral differences that could also affect the outcomes after surgery, even though it feels much more biological. There are a lot of behavioral things going. So I just wonder if looking within the groups to see, is insulin resistance a determinant of outcomes in the white group? You know, I picture these distributions that overlap, and we usually report on the mean. So there's a distribution within each group, and I'm just wondering if you've looked at that at all.
I can tell you that in our the study that we published, there were 2 clusters of Caucasians. One that didn't do as well, and then the other that did really, really well. And in the African American group, it was just one cluster that didn't do as well. And then in terms of insulin resistance, we're looking at that now. What we're doing now is we're trying to track when it happens in Caucasians versus African Americans. We're doing it in the lab. We're doing clamp studies, but we're also looking at the Framingham data and the Jackson Heart Study data to try to figure out when in the trajectory of obesity, when in the lifespan does the insulin level rise. Because it looks as if in African Americans there is hyperinsulinemia early on. And you know, you can postulate that that is not biological, but if it's not biological, then we have to look at the different types of foods that people are eating. And maybe that's more has to do with SES status and all of those things. But it's a tough thing to study, so we have to do it in the lab, and we are doing the clamp studies now.
Great,
So.
thank you.
Well, our time is up, but I want to ask the audience to join me in thanking our panel.